Adverse cutaneous drug eruptions in pediatric age group. The topic to be presented by Dr. Ram Gulati, Senior Consultant Dermatologist from Jaipur with a specialization in pediatric dermatology.
A very good morning to everybody. I'm highly thankful to Dr. Sandeepan Dhar, Dr. Sandeepa Sir, or Sandeepan Da as he is very affectionately called. I think he's probably been a mentor of kind of pediatric dermatology across India and abroad. And the opportunity to be here, I think from the west side of India to east side of India is a big journey. But nowadays, I think with all the connections we have, it just takes a few hours. Thankfully, adverse drug reactions remains the same, whether they are in the western part of the country or the eastern part of the country or anywhere in the world. Even though genetics is making a huge difference to the way we are going to tackle adverse drug reactions probably in the future. Now, why are drugs important? So the first thing is, can we do without drugs? No drugs, no adverse drug reactions, so simple. If you look at just a couple of statistics, about a quarter to a third of children died before puberty. That was in ancient Egypt and 19th century US. And what changed this? I think as all pediatricians are here, and I think you're all, as we'll say, vaccinators. Vaccines is one thing which made a huge difference. Improved sanitation made a difference, and it was specific pharmacotherapy which made a huge difference in improving the mortality rates. So why bother with the adverse drug reaction? So if you've got a specific pharmacotherapy improving your lives, the problem now is that we have all been probably listened to or have read about the sulfanilamide therapy problem. There were, in 1930s, the diethylene glycol was added to sulfanilamide, and that caused nephrotoxicity and numerous deaths. And then we had the thalidomide tragedy. So all drugs or medication that we are using are potential toxins. So we are dealing with toxins day in and day out. We used to study forensics and toxicology. So in fact, we are dealing with toxicology on a daily basis. Almost up to 1% of the patients who are started on a new medication will have some kind of a cutaneous adverse drug reaction. And if you classify the drug reactions, you will see either they're classified as type A and type B. So type A is predictable. So you know that it is just an altered, some kind of an exaggerated pharmacologic response to a drug on a therapeutic dose, or you have probably dosed extra, or the child has taken an overdose. So you know what the effect will be. So side effects, secondary effect, interaction, toxicity. But what we are really worried about are the unpredictable ones, and that is what we're going to probably deal here. So it is intolerance, allergic or pseudo-allergic reactions, idiosyncratic reactions, psychogenic reactions. This is something you really cannot predict. And that is where you have to just keep an open eye. And when you deal with 5 A's of dealing with a possible drug reaction, the first A is appreciation. So what is appreciation? That simply means that you have to keep an eye open, that this can be a drug rash. If it doesn't come into a differential, you will never think about it. So there was an adage told yesterday that the eye sees only what the mind knows. So if the mind doesn't actually even think of a drug rash, you will never keep it as a differential. So once you appreciate it, then definitely you collect your data, assess the patient, do investigation, analyze the investigation and the clinical scenario, and then assist the patient as needed. And the aftermath simply means that just don't leave it there. You have to sit with that child and the parent at the end of the day, explaining to them, this is the drug which possibly caused, these are the cross-reacting drugs, and this is something which needs to be avoided at all times. So unless that is done, you're probably going to see that child in a worse shape, maybe in coming months or years again. So cutaneous adverse drug reaction, WHO database says that almost 35% of the adverse drug reactions are cutaneous adverse drug reactions. And predictable, as we said, I'll just give a couple of examples so you can see this was a predictable side effect of a topical steroid. So this was, I think a couple of times it was discussed yesterday, and it has again been very thoroughly ingrained nowadays in dermatologists, and it needs to be ingrained into the RMPs and the people who are dealing with not only children but the adults as well, that topical steroid, they should be used very carefully. So what you can see here is it's a tinea or a ringworm, and there's a big circle, and in between there are small circles. It's ring in rings. So ring in ring is actually a phenomena which is very pathognomonic of topical steroid modified tinea. It can cause striae, so you can see that. So this one you can see a big ring here and then multiple rings inside. So what topical steroids cause is an immune suppression locally. So the fungus which is there in between, the moment it gets some opportunity, it actually comes, and therefore you can see multiple rings within a big ring. So this is steroid modified tinea. You can see striae. You can see even a Cushingoid status because of the use of steroids in a child with tinea. Perioral dermatitis is a condition where for some reason the people start using topical steroids on the face, and gradually you can see these erythematous papular lesions around the mouth. And until the steroids are stopped, this doesn't actually go away. And then the topical steroid modified phase or topical steroid damaged phase causing hypertrichosis. So this is something which is a predictable side effect of topical steroids. And I think the IADVL itself, it had the theme of fight the topical steroid misuse in 2019. And it still stays the same, that we should be fighting this and stop the fixed drug combination with clobetasol and all these different. So if you have to use a steroid, use only one steroid for a particular indication, and you should know what you're using for. If you don't have a diagnosis in hand, then definitely better not to use a topical steroid. Cyclosporin-induced hypertrichosis, again, there are multiple drugs which can cause hypertrichosis as listed there. And these are, again, predictable ones. So these are all type A, which you will know that this can happen. And you can probably modify your medication, you can probably reduce the dosage, and you can tackle with them. But what we have a problem with is the unpredictable or the type B reactions. So we'll start with the most common one, which is the simple morbilliform drug reaction or the maculopapular drug rash, which you see most commonly either in adults or children. You will see this kind of maculopapular, so it is erythematous, small papules. You can see some flat lesions. So it is quite symmetrical, and you can involve the entire body. It is considered to be kind of an interplay either with the virus or the drug. Now, EBV and amoxicillin rash, I think we all have probably read it at some point, that if you give aminopenicillins in a child with, in a patient with EBV, you can see a rash. It used to be said that it was probably 80 to 100%. Nowadays, they think it is probably less than that. But it is probably the interplay of the immune system, which is actually trying to fight off the virus, but in the same time makes you susceptible to a drug interaction as well. There's probably an interaction of both of them. It is considered to be a delayed T-cell hypersensitivity. And once you have a morbilliform rash or a maculopapular rash with one drug, that person is at a higher chance of developing a similar rash with another drug as well. Any drugs can cause it, but most commonly you get these antimicrobials, especially beta-lactams, NSAIDs, and anti-epileptics. So I think if you will look at all the drug rashes which I'm going to present, you will probably see these three groups probably being very common in many of them. So when you're giving antimicrobials, almost half the rashes that you see are usually with antimicrobials. And that is simply because they are the most commonly used drugs. Then anti-epileptics and NSAIDs, one has to be very, very observant of any rash developing. So simple rashes, simple morbilliform rash usually occurs after 72 hours. So if you have got a child who had a viral infection or a possible bacterial infection, you gave a medication and the drug rash, this rash is coming very, very quickly, within a day or two, more likely to be a viral than a drug rash. But again, you have to look at the evolution of the rash and keep the child under observation. So beyond 4 days, once the child has a rash, the next time the child has a drug, the child may have a rash a bit more quicker. So it doesn't actually add on every time. I think yesterday this was already discussed, how to differentiate between the viral rashes and the drug-induced rashes. And I think Sandeepanda probably had the slide. And so with the viral rashes, you will get a prodrome of fever and malaise and things. Usually you don't find that much unless you have got a significant reaction. For example, the SJS and TEN reactions where you can have a small prodrome. The onset is usually sudden in viral, but again, drug-induced, it can vary depending on what kind of a rash you have. The viral rashes usually either are peripheral or central, but the drug-induced rashes can involve probably pretty much all over body. Palms and soles are much more commonly affected in drug-induced rashes. If you look at the nature of the rash, it is quite bright and erythematous in viral rashes. But in drug-induced rashes, very quickly the rash becomes dusky in color and confluent. The viral rashes usually are going to go away by themselves, but the drug-induced rashes need withdrawal of the drug. And then definitely if you take a history, there should be a temporal correlationship between introduction of a drug and a rash coming afterwards. Why we are so much stressing upon differentiating? Why not treat it as a drug rash, stop the drug and maybe deal with the child? There was this study done in 1998 by Huang and others, and they said that when they tried reintroducing the drug in a child who had a history of morbilliform rash, only 8 children out of 62 developed the rash again. That simply means that majority of these children were just labeled as drug rashes, and they did not actually have drug as the implicating factor. Secondly, the problem is many of these drugs will have cross-reacting drugs. So this child will be labeled as a drug reactor for entire life. So you are probably limiting the therapeutic armamentarium for this child if we are labeling it incorrectly. Usually they start settling within a couple of days of drug withdrawal, and only symptomatic management is needed. What is a warning sign for a severe reaction? So one has to always look out for the presence of mucosal involvement. If there is systemic involvement, if there is a facial swelling and lymphadenopathy. So these two things were discussed yesterday as well. They are something which can also be seen in DRESS syndrome, which is a severe reaction. Blister formation, so anything which has a water-filled blisters, pustules, denuded skin. So you can see denuded skin, for example, toxic epidermal necrolysis. You can see in bullous SG syndrome. You can see in bullous FDs. Or if you've got a persisting high fever with a corresponding rash. So these are something which are warning signs for a severe reaction. And these are not, you can't just simply give a one-time treatment and tell the child to come back in 7 days' time. So this needs a continuous monitoring of the child. If we look at the reaction, which is, again, looks like a very simple morbilliform rash, there's hardly a difference in this rash and the one we saw before. But this is a DRESS reaction, which is drug reaction with eosinophilia with systemic symptoms. Again, if you look at the drugs implicated, here aromatic antiepileptics are very, very commonly implicated. So think of phenytoin, phenobarbital, carbamazepine. Lamotrigine is something which can cause significant DRESS syndrome and severe reactions. Sulfas, including dapsone, allopurinol, vancomycin, cephalosporin. So if you look at the whole list of drugs which has ever caused DRESS, you probably will fill pages. But these are the very common ones where you have to keep an eye. For example, lamotrigine is something where nowadays if it is being given, the child is, the parents are told actually on day 1 that if there's a rash with lamotrigine, you stop and come back. So that is the nature of the rashes with lamotrigine. So they take about 2 to 6 weeks to develop. They can be a prodromal fever. And then 85% of the rashes, they just look like simple maculopapular rash. But in 15%, you can have a different variety of rashes. So you can have urticaria, you can have target-like lesions like SJ syndrome. They can be pustular lesions. They can be blistering rashes. Usually these rashes start on the face in DRESS syndrome. They can be associated with facial edema. Facial edema is very, very characteristic to an extent that it has been put into the criteria for diagnosing DRESS syndrome, but those criteria are made for adults. They're not validated for children, but I think we just still follow. Mucosa are involved in more than half, but most of them will be just erythema and nothing else. The rash tends to start on the face and then go down. You will see lymphadenopathy. So if it stays that way, we are happy with it. But the problem is that many of them are going to go and involve the liver. They're going to involve the other areas. So hematopoietic system, definitely you see eosinophilia, leukocytosis, and hematologically, and then hepatic is increased transaminases, and you can even have significant liver involvement in these children. And then there can be other internal organ involvements as well. So what is recommended is that you always do something called a timelining of a drug rash whenever you are thinking of a drug rash. So it's just taken from one of the articles. The timeline is that you put a date here, and then this is the first medication started on this date. This is the medication starting on this date. This is the medication on this date. A single dose was given of a medication at that point. Another medication. This is where the sore throat and eyes had a problem. There was fever. Here the skin blisters were there. So you have got a timeline, and you can judge where exactly which drug might have caused it. So drawing a timeline helps in reducing the drug which might have caused this reaction. These are the criteria. One of the criteria, so you've got the Japanese criteria, J-scar. So again, we have discussed all of these, but they are not validated in children per se. If you want to do the blood test, usually a simple profile of CBC, liver function test, renal function test, urinalysis. Because hepatic involvement is there, some authors recommend doing a coagulation profile at the same time. Now, thyroid function test, it has been recommended. One of the groups said that almost 12% of the children might end up with autoimmune thyroiditis. So you do have a baseline thyroid function test, and that should be repeated at 3 months, 1 year, and 2 years. The recommendation of one of the groups, which I found that thyroid abnormalities were very common post the DRESS syndrome. Treatment is withdrawal of the offending drug. Oral versus pulse systemic steroid, usually we go with oral steroid, but it takes a long time for these to actually be tapered off over 3 to 6 months. And the other things which have been tried are cyclosporin, IVIG, and plasmapheresis. There is a deemed role of HHV6, that reactivation of HHV6 might be causing DRESS, and there are groups which are coming up with the role of antivirals in DRESS syndrome, but I think we still need more evidence on that. Urticaria angioedema, almost 5% of the cutaneous reactions are urticarial. They are type 1 reactions, but sometimes non-immunologic mast cell release can cause histamine and other mediators. Individual lesion is going to last less than 24 hours, so that is the hallmark. And as Dr. Kiran Ghosh said, that if the lesion is lasting more than 24 to 48 hours, start thinking in terms of an urticarial vasculitis. Do look out for a systemic signs if the child has acute urticaria. For example, if acute urticaria with bronchospasm, with hypotension, other features, you might be dealing with an anaphylaxis rather than a simple urticaria. I think role of RAST and SPT is there in type 1 reactions, which can be utilized if you're thinking in terms of, but we don't have a very good kit for dealing with drug-induced urticarial lesions. Serum sickness-like reactions, serum sickness by itself is a type 3 reaction. So you will have immune complexes, you will have complement and others involved, but serum sickness-like reaction is just a kind of a pseudo serum sickness. You don't have any of those problems, but characteristically it just looks like one. So you have an urticarial rash, you have malaise, low-grade fever, arthralgia, lymphadenopathy, and usually such reaction will come 1 to 3 weeks down the lane of starting the drug and settles very quickly within a couple of weeks once the drug is actually taken away. It used to happen very, very commonly with cefaclor, but that has been hardly used nowadays. So you see much less of serum sickness-like reactions nowadays. This one I've just put in. Again, it is one of the, if you look at papulopustular lesions, do think of steroids as a cause of monomorphic acneiform lesions. These are papulopustular lesions more on the trunk and extremities as compared to face, and all lesions look exactly the same. So these are because of there was a history of injectable dexamethasone here in this child, given apparently for a fungal infection. Again, that is a predictable thing. So it is a predictable reaction to steroids, but I've just put it here as an addition. Acute generalized xanthomatous pustulosis, or AGEP. I think there was a mention yesterday of AGEP when differentiating with pustular psoriasis. So this is a very rapid onset rash. Within a week you will get this. The rash is usually associated with fever, which may be absent in children. 20% of the times you will see a mucosal erythema, high white cell count neutrophils. So it happens so rapidly that the child's body is completely filled up with hundreds of thousands of pustules on an erythematous background. Usually what you need is a quick withdrawal of the drug and the rash starts settling very, very quickly. Most commonly you see with aminopenicillins like amoxicillin and ampicillin, but cephalosporins, clindamycin, paracetamol have been implicated as well. And in children, it is not just the drugs, but the viral infections like parvovirus, Coxsackie, CMV, and mycoplasma can lead to AGEP as well. Photosensitivity can be seen, especially with naproxen. There are a number of case reports, or NSAIDs as such can cause photosensitive reactions in children. There have been cases with childhood immunobullous disorders, drug-induced, but they are very less. So childhood pemphigus, bullous pemphigoid, linear IgA disease you can see with drugs. The SJS, or Stevens-Johnson syndrome, or toxic epidermal necrolysis is the most dreaded ones. I mean, thankfully, bad SJS and bad TENs are less common in children as compared to adults. And when this is the Bastucci-Garin classification we used in adults, pretty much used in children as well. So if it is just based on the body surface area involved, less than 10%, 10 to 30, more than 30. So if you have less than 10%, and if you have got very typical raised targets in localized area, you say it is a bullous EM or EM major. If you actually have less than 10% with flat atypical targets, so target lesion is a characteristic lesion of Stevens-Johnson erythema multiforme or Stevens-Johnson syndrome. Target simply means that there are 3 zones: central dark, you can see a central dark, peripheral red, peripheral pale, and then a darker one on the outside. But these are atypical targets, you only have 2 zones. So atypical target means you don't have the characteristic 3 zones, you have either 2 zones, and these ones are much more commonly seen in SJS and TEN. So in between 10 to 30% is an overlap between SJS syndrome and toxic epidermal necrolysis. More than 30% is toxic epidermal necrolysis. But again, if you are seeing sheets which are coming out, for example, on the right side, you can just see that the sheets of the skin are coming out and there are no dots, then just above 10% of the body surface area involvement is categorized as a toxic epidermal necrolysis. It is associated with prodromal symptoms. You will have malaise, fever, lymphadenopathy, fatigue, sore throat, morbilliform to targetoid rashes initially, but then they can all kind of become confluent and become one, and you can have significant systemic involvement at the same time. The drugs are again lamotrigine, carbamazepine. Again, you're coming with anticonvulsants, NSAIDs, antibiotics, and paracetamol. Again, almost a similar group that we have seen. In children, mycoplasma and HSV, especially mycoplasma, can cause SJ syndrome as well. And sometimes you have just the mucosal involvement, which is called the Fuchs syndrome, and it is considered to be a localized SJS or a mucosal SJS secondary to mycoplasma. In this, you have to introduce a macrolide at the same time for mycoplasma to just make sure where you have got a mucosal involvement, you check for mycoplasma IgM and go that way as well. Management this, again, timeline, history, examination, take the drug off. Ophthalmology is very important. Just make sure if you have got a toxic epidermal necrolysis, ophthalmology referral has to go on day 1, because sometimes you need an amniotic membrane graft on these to just save the eye. They're usually taken care of in a burn unit. There is a question mark whether you need steroids, but the recent guidelines say that steroids should be used initially for a shorter period, but nowadays cyclosporin and IVIG and TNF-alpha inhibitors have been tried as well. Just a fixed drug eruption, it's an eruption which comes from the same place again and again after reintroduction of a drug. You can have a simple FDE, which is a pigmented lesion, which is itchy, settles on its own. You can have a blistering in the center called a bullous FDE. Again, the drug implication is pretty much similar. Just need topical steroids and antihistamines to deal with it. If you're going to give it again, the rash is going to come back again on the same time. But the problem sometimes is that if you give it again and again, you might the rash might increase to cause a widespread FD or multiple FDs. And at some point, you can even think of blistering, quick drug eruption, multiple lesions. If they just give way, it will almost look like a toxic epidermal necrolysis. But here what you see is that the intermittent skin is normal and it is not red. Mucosal involvement usually is not there, and the child is usually much better as compared to TEN. I think the last slide is just that if you see a rash, think of a dermatologist. And even sending a photograph to a derm colleague actually sometimes does wonders. And I think we have all seen many a times. Widespread rash, diagnosis in doubt, atypical rash, sick child with a rash. I think always get a dermatologist opinion at the same time, because even if the primary treatment is a pediatric treatment, it can pinpoint to a particular diagnosis and investigation which can be really helpful in saving a life. Thank you very much. And the last line is withdrawal of potential offending drug. If you are thinking of a particular drug and it is not something which you needed straight away, just the first thing you do is take that drug off, and then we can actually deal with the child. Thank you.